That's how.
Hi, everybody. All right, looks like I got a lot of my usual suspects here. It's a good sign. We'll hang out for about one more minute before we officially start. All right. See a lot of my friends in here. Okay. Well, let's not waste anybody's time here and we'll get this rolling. Welcome to today's session of the community table, and our topic today is serving homeless persons with serious mental illness. And our presenter is Katie Lee, who's coming to us from Baltimore, from the National Health Care for the Homeless Council. And as I was telling her a while ago, they've done an excellent job with their previous presentations. So I have no doubt that this one is just going to be as good. And so with that, I'm going to turn things over to Katie.
Thank you so much. It's so great to be with you all today. Um, as we go through today's topic, this is something that is particularly near and dear to me as I am a licensed clinical social worker. As Laura said, I'm in Baltimore, Maryland, and worked at the Healthcare for the Homeless for over a decade before joining the council. And then, but I got the great opportunity to supervise frontline staff, community health workers, outreach workers. Really, my focus was engaging clients in care. So once they were actually connected to the clinic, in some ways our job was done. But as you all know, that often that connective tissue of outreach workers and health workers and peers in the community is really what holds people in care. But so I'm delighted to be with you all today, both with my hat as a clinician, also as having had the great opportunity to work with community health workers and peers in this engaging to care and really thinking about it's less about what a condition is or isn't, what the diagnosis is, and really how it is about helping somebody address their symptoms, live the life that they would like to lead. And so that's what we're going to focus on today. So really excited to spend some time with you. And please, I welcome participation. Feel free to raise your hand, come off of mute, put it in the chat. I do have it, anyone who's ever presented PowerPoint presentation mode makes it a little bit limited in terms of what I can see without having to look around too much. So please, if you have something and I'm not acknowledging you, jump right in. I'm delighted to have your conversation, and we're a small enough group that we have time and space for that. So really looking forward to this today. Just a little disclaimer, the council is HRSA funded, but what I say does not necessarily represent their official positions and views of HRSA or HHS or the US government. So that's just the exemption that I do not speak for them. I start all of my presentations with a land and labor acknowledgement. Our conversation today includes all of us, and we are located across many communities. Most of our communities reside on unceded ancestral land or acquired by unhonored treaties. We acknowledge the people of these lands, past and present, and honor with gratitude the land itself and its people. We also honor the brilliance and humanity of all immigrant labor, including voluntary, involuntary, trafficked, forced, and undocumented people whose labor remains hidden in the shadows but still contributes to the well-being of our collective community. By recognizing the land that was taken from First Americans and the forced labor that was provided by enslaved Africans and Black and Brown people, we strive to take steps towards creating a more equitable and just world for us all. Want to give you a quick overview of what you can expect from today, but please, if there is something you were hoping to accomplish today or conversation, a topic that you don't see here, let me know what that is in the chat. I will do my best to incorporate it as we go along. We're going to do a little bit of level setting around some terms of serious mental illness, make sure we kind of all know what we're talking about, going through a few definitions of those terms. We're going to talk quite a bit about a lot of the focus here is how homelessness impacts, worsens, exacerbates, creates conditions of serious mental illness. The interface of mental health and substance use, certainly incredibly prevalent in our world today. We're going to talk about some tips for both recognizing conditions and then also how you as a staff person can de-escalate a situation, and then review question and answers. But I truly mean it. If you have anything that you want to talk about as we go along, by all means, please just chime right in. So a few learning objectives, don't have to go through that. We're going to get right into this. So I want to just go with some introductory facts, kind of non-disputable about when it comes to mental illness. So nearly 1 in 5 US adults are living with a mental illness. This is as you know, with data, very often we're working with data from several years ago. This is a particularly interesting one because the data was published during the year that the pandemic started. So we actually know this is higher due to the stress and strain and challenges that the COVID pandemic caused in our country. But conditions vary in degrees of severity and range from mild, moderate to severe. Those are actually terms that we use in behavioral health to categorize a person's symptoms. But it really is just that. It is about how a person is experiencing that condition is more significant than which of these categories somebody has labeled them in. And very often a person experiences along this continuum throughout their life. And there's a lot of different factors that we're going to talk a little bit about that can cause somebody's symptoms to worsen or improve. Mental health is like any other condition that can benefit, but not be cured by medication. So medication is the path or is a portion of the treatment plan for many individuals. And like most health conditions, there are symptoms that are reduced, but it is not a curable condition. And at times throughout a person's life, due to a myriad of reasons, the efficacy of that medication will change. We also know that over a person's lifespan, the recommended treatment will also change. And so there is likely going to be an evolution of a person's health profile and the ways in which it is treated throughout their lives. And there's significant impact from other health conditions that may onset later in life. So things that we know that happen more often as somebody ages, whether it be an increase in blood pressure or other onset of other conditions that may be more serious, such as cancer or strokes or things that happen as a person ages. Those can also impact mental health or the efficacy of the medication that the person is taking due to other things that are in their bodies. And that there is significant racism in mental health. This needs to be named in every conversation because it impacts both a person's desire to seek treatment as well as the way their symptoms are perceived by somebody who is willing to serve them or who is trying to engage with them. How we view a person's symptoms is often subconsciously or maybe intentionally informed by race. And this happens at a systemic level. We know that there are people of color have experienced worsened mental health during the pandemic. They also face disproportionate barriers to accessing mental health. And all of these layer into that stigma that is incredibly prevalent in the world of mental illness and mental health. So a working definition with SAMHSA around behavioral health needs is the promotion of mental health, resilience, and well-being, the treatment of mental and substance use disorders, and the support of those who experience and or are in recovery from these conditions. So it's really behavioral health is a very broad term that encompasses the recognition and treatment of mental health and substance use disorders. This includes promoting mental health, the resilience, the well-being, so those factors that keep a person well. The treatment of mental health and substance use. So when somebody is experiencing symptoms that become negative for them and they would like to seek out changes, that is part of the treatment and part of why people seek treatment. And then the support of those who are in recovery of this experience means that recovery can be defined by the individual. So we need to be thinking about the fact that recovery looks different for every single person, and it should be defined by them. It is likely that it will evolve throughout their life, and that it is something that they might choose to address some of the conditions they are experiencing in their life while not doing others. So just because a person is experiencing symptoms of behavioral health, they might choose that they would like to change some of their behaviors in terms of substance use, but are not yet interested in engaging in medication for their mental health symptoms. And that we should be thinking of these as holistic pictures of the individual, and how they define what their symptoms are is really going to inform what they want to prioritize. So something that we might view as being a negative may not be problematic for them. And so we need to recognize that there are factors that they themselves have reconciled and want to live with certain features, and others that they might have some poor insight or inability to recognize the impact of a symptom on their ability to achieve certain goals they have. So sometimes we are seeing that disparity, and that is our role. It is less about what is the condition that is causing it and how can we help somebody have some insight into their own symptoms to be able to reflect, do we want to make a change on how we are currently treating or coping with their behavioral health conditions? So not all mental illnesses are severe. So any mental illness is defined as a mental, behavioral, or emotional disorder. It can vary in impact and range from no impairment to mild, moderate, and even severe impairment. So really thinking of how it impacts that person's ability to live their life as they would like to. Serious mental illness is both something kind of a broad category we talk about, but actually has a category that is defined medically. And it is defined as a medical, behavioral, or emotional disorder resulting in serious functional impairment, which substantially interferes with or limits one or more major life activity. The burden of mental illness is particularly concentrated among those who are experiencing disability due to severe mental illness. So really thinking of that burden and impact on the individual. So how is it impacting their major life activities? And what we mean by that is we think of their abilities to conduct their activities of daily living. So taking care of themselves, eating, bathing, things that in our society we have defined as being indicators of someone's ability to live independently. Then also their ability to do things that are meaningful. That may be work, that may be social engagements. Not everybody is age appropriate or is it necessary or wants to work, is able to work, but that doesn't mean that they have a serious mental illness. There could be other conditions or other reasons that that is not one of their current life activities they are striving towards. So a lot of this is about hearing what is important to the individual and then seeing if the behavioral health condition is impacting their ability to reach those goals. So, as I said, serious mental illness is also an actual category in healthcare that we have categorized certain conditions as potentially being in meeting the criteria for being a serious mental illness. Now, it is important to note that all of these conditions are not necessarily severe in their symptoms. It is that they can reach a level that categorizes it as a serious mental illness. So when we talk about this, we think of psychotic disorders, bipolar disorder. Bipolar disorder is that experience of very high highs and very low lows. So major depression being a component of bipolar disorder. And both bipolar disorder and depression can have a presence of psychosis, so a person experiencing psychotic symptoms, but maybe not actually standalone, separate from those experiences of mania and depression. Anxiety is a perfect example of something that people are living with and functioning with every single day of their lives, and it may not consistently be impacting their ability to perform their live their life as they would like to and perform their activities of daily living. But there are times when the anxiety may get so severe, or there are cases of anxiety that are so severe that it significantly impacts a person's ability to live the life they would like to. And then personality disorders, which we're not going to talk a lot about today because those really fall into a category that are more about a diagnostic code than they are about how you're going to engage with a person. Symptoms can vary greatly for each individual, and there is no particular symptoms that equals a definitive condition. But some of the things that you might notice when you are talking with someone are racing speech, or they seem to be responding to something that you do not see, whether that be that they are talking to or they are agitated by something that is not visible or that you cannot hear yourself. You might also notice the exact opposite, somebody who you have worked with for a period of time that is suddenly either not speaking with you or showing no emotion whatsoever. If this is somebody who you are used to engaging with and having animated conversations and the ability to dialogue, and suddenly they're not engaging in those conversations. Maybe they are sleeping more or less, kind of distance from what you are used to seeing them as. Hopelessness can also be a symptom of serious mental illness, and also changes in appetite, changes in sleep, just changes in behaviors. And I think one of the things that is most beneficial about frontline staff is you all are very often in the perfect position and have the ongoing relationships to be able to notice these changes first. And sometimes they are generally not an overnight change where it is so obvious. It is not like switching a light switch and suddenly the person has them and then doesn't have them and then does have them again. But you often are engaged in conversation where signs and symptoms of these conditions are presenting themselves in a way that is noticeable to you, that might not yet be noticeable to them, or if they go see a provider or they engage in other activities at a meal program or short interventions or short engagements where they are not seeing the person experiencing those symptoms. They are focused on whatever the activity is that they are trying to accomplish and moving about their day. And so these symptoms can either be suppressed a little bit or just go unnoticed because of the busyness of all the activity of wherever they are around them. But you all, when you are in a position to not necessarily be working towards something specific, or are actually working towards something very concrete, but it is not related to health, a person may actually show some of their symptoms sooner to you. And you can be a great indicator if they are engaged in care or are needing to engage in care, of raising these concerns, of noticing these differences. We talked a little bit about it, but I want to take a step back again and talk about mental health and stigma. In many communities, and really across our country, We view mental health as a personal flaw rather than a health condition. So, what I mean by that is it is viewed as they are making choices to act in a certain way, or they're making choices not to get help. That it is they were raised in a way that that a person's symptoms are what they are, that this is done by how a person was nurtured rather than it being something that is happening within their body. Really, a disconnection of recognizing that mental health is not a choice and that it is linked to very specific chemical things happening in a person's body that is impacted by the same things as any other health condition. And so it is the person's to fix rather than something that our community needs to recognize we need to assimilate towards. We need to create a community that allows space for differing levels of behavioral health conditions. We have set this norm that favors white people, that favors healthy people, that, this ableism perspective, this centering a supremacy or what we view as being ideal. And then anybody who doesn't meet that, it is on them to adjust. There are also very real cultural stigmatisms to admitting to a problem, to accessing treatment. This can be about race. This can be about gender. This can be about family roles, that a person is actually demonstrating weakness if they seek help for a condition rather than I view it, and it should be viewed as a strength to admit that there are things that are not working for a person and it's time to get some support in making it so it does. And there is a long history of racism and trauma that has led to mistrust in healthcare. And so it decreases access to care. When people don't see providers who look like themselves, or they know family members and friends or members of their community who have been mistreated by a care system, they themselves are not going to be as inclined to go get care from that system because they remember what happened to their family member or friend or their community member. This is very important to think of as we think of engaging anyone for any reason. We have to recognize that depending on how we come in, when I entered any situation, I worked at Healthcare for the Homeless in Baltimore. So that was on my badge. Sometimes it was on my outreach shirt. It was an identity I was proud of, but I also know that it was a barrier for some for being willing to trust me. So my responsibility there was to demonstrate my trustworthiness and that it was not affiliated with the logo on my badge or my shirt or my backpack, but that I had an investment in this individual and helping them achieve whatever their goals were. And that it was part of that earning of trust was to demonstrate that not everyone in healthcare is the same and that their experiences are very real. And not every experience is going to be that way. And the way in which you earn that trustworthiness is to prove yourself trustworthy, is to follow through on actions. One of the biggest things I taught my outreach workers was under promise and over deliver. So do not say something you can do unless you are absolutely positive that you can do it. And even if you are positive, promise this and show up with this, because that is what is going to demonstrate to somebody that you are trustworthy, that you are not just giving them lip service and trying to make them hear or let them say to them what they want to hear. Because that is what happens in these large systems, particularly as somebody is experiencing homelessness. They are operating through very large systems. If they are in a shelter, there is a whole homeless service continuum. If they are receiving benefits, whether that be through Department of Social Services or the Social Security Administration, those are very large systems they have to operate in. They also might need to operate in large systems to gain access to their meals. So things that we all operate in large systems, but there are things that I get to do in my private life that can stay private, whereas a person experiencing homelessness has to live that private life in public and very often depends on these public systems for those core things that they would like to be able to provide for themselves. So all of that is going to lead to layers of mistrust, layers of reservations, of hesitation to engaging in care. So we know that there's a higher prevalence of people with mental health conditions among those experiencing homelessness. There are higher rates of co-occurring disorders. So what I mean by that is that mental health and substance use together. And that is due to a myriad of reasons. We'll talk a little bit more about it, but a lot of it has to do with coping and a way of trying to address some of the mental health symptoms by using other substances as a form of medication. Accessing treatment is more difficult. Barriers such as health insurance, identification, having a place to store your belongings if you are going into treatment, needing to adhere to a shelter schedule when appointments are happening after hours. There's a lot of things that make treatment more difficult for somebody who is experiencing homelessness and has to live their life in that system. Homelessness makes existing conditions worse and can cause new conditions. So we talked about that anxiety being one of the serious mental illness conditions. We also know things such as trauma, which are very serious, both on their own as a behavioral health condition, but also the way in which it triggers other health conditions. And things like inconsistent food, inconsistent sleep, inconsistent access to water and rest, and meaningful rest that is safe and secure, something that is just most people cannot feel if they are living in a large shelter. All of those can exacerbate a pre-existing condition. And that lack of stable housing, income, food, transportation impact the efficacy of treatment. So when you don't have those core things met, or you are constantly having to strategize between where am I going to sleep tonight, what meals am I going to be able to eat, where am I going to get those meals, and can I get to the necessary appointments? And if I can't, which ones do I prioritize in order to be able to make any treatment method more effective? And what we would like them to prioritize as a provider, as their care team, is likely going to greatly differ than what they need to prioritize for survival. So the relationship between behavioral health conditions and homelessness is both complex and bidirectional. So we talked a little bit about the trauma in particular being something that impacts, they can contribute to experiencing somebody becoming homeless. So somebody experiences a traumatic event can cause homelessness, but then also while a person is homeless, they are more likely to experience a traumatic event or to have the ongoing trauma of the uncertainty and instability of homelessness, creating that complex trauma in a person. And the same bidirectional for behavioral health challenges. As we said, it is one does not necessarily cause the other in a single directional way. So homelessness can cause behavioral health challenges, but also behavioral health challenges can lead a person to experience homelessness. And so we know that there is a strong relationship between these three kind of pillars or cornerstones of behavioral health. And as we said, homelessness makes mental health worse. So it can cause lost or stolen medication. So somebody who had a treatment plan and suddenly their medication was stolen or lost due to the instability of their housing, that's going to change their ability. They can't necessarily just get more medication. That's not the way our healthcare system works. No matter how care teams will often try their best, but it can be difficult in this world of insurance and regulatory requirements around the frequency that medication can be issued. Talked about decreased access to treatment. Living among lots of people can cause anxiety, it can cause stress, it can cause tension, interpersonal tension, so relationships that become challenged or strained. It can be traumatic in an ongoing way. So that complex trauma, this idea that it is not a particular one single short-term event, but this ongoing drain on our response system can be traumatic. And it often creates interruptions in care, not by choice necessarily, but the homelessness, especially if somebody is street homeless or living in encampments, and that gets swept or disrupted, their ability to access their care and their providers can be interrupted in significant ways if they are forced to move to a different location and where they don't have the same access. And that overall lack of stability impacts their ability to prioritize what they would like to prioritize. So sometimes, even if they would like to prioritize addressing symptoms, other basic needs, such as housing and food, have to take priority because of that stability that they no longer have control over. And really, just to bring this home, these symptoms can be new or can be exacerbated. We see quite a bit of depression and suicidal thoughts among people experiencing homelessness due to it may have been a pre-existing condition that has worsened, or due to their situation and that feeling of hopelessness, that feeling of that things are not going to change, or the experiences of trauma and the lack of desire to continue to live like this can cause those real serious emotional responses that need to be paid attention to and taken very seriously. And we know people experiencing homelessness have a higher rate of adverse childhood experiences, meaning there are things in there before they hit adulthood that have impacted the trajectory of their overall health. Now, adverse childhood experiences impact both the conditions themselves, behavioral health and medical conditions, as well as the treatment modalities and access to treatment that a person will have had throughout their life. So these are often the root of substance use among people experiencing homelessness because they lead to social, emotional, and cognitive impairments. And then a person is interested in trying to address those symptoms they are experiencing. And due to all the barriers that we've discussed in accessing care, one of the more readily available accesses of treatment is often an illicit substance or maybe a prescription substance, but that is purchased on the streets from somebody else who had it as a medication.
Okay, did somebody raise their hand? That popped up real quick, but I didn't see who it was. Sorry to interrupt you.
Thank you. Oh, certainly.
If you have a question, put it in the chat and I can unmute you.
Awesome. And while we're waiting, if somebody, please feel free, chime in. I'd welcome your input. But it can be very difficult to know what is a mental health symptom and what is something that is caused by substance use. But I would put the challenge of, does it matter in the moment? Does finding out the reason why in that moment matter for how you are going to engage with the person, how you are going to direct their care? I would say it should continue to root your engagement in empathy and prioritizing whatever their goals are. And then it is something that you can work to discover and see how the symptoms change over time in determining of whether or not this is something how you might go about supporting them. And so hopefully through building trust with a person, you will have a clearer understanding of what is happening as a health condition. And maybe if there is a presence of substance use that may or may not be impacting those symptoms as they present. There are things both in a person and externally that can make mental health symptoms worse. So we talked a little bit about changes in medication, poor sleep, relationship changes. This can be interpersonal with an intimate relationship. It can be familial. It could also be with providers, with the systems in which they are working. So maybe it is also their relationship to an organization has changed, whether that be a provider or an access to a shelter or access to food. All of those can be very triggering to a person. And then a cycle of illness. We talk, as we discussed, new illnesses coming on. We know that over time, even chronic conditions that were once well managed by medication can change in the whether the medication remains effective. And so something that was previously well balanced for somebody, it may be no longer responding well to the medication, and that can impact their behavioral health. There are also some very real external factors. Weather. Now, what I mean by this is both significant, like big weather events. So what is happening right now in Florida is certainly a seismic weather event that is going to drastically impact the stability of particularly of people experiencing homelessness in that area. So the systems that they access will change. They may lose all of their belongings because it is unsafe to be outside, or depending on where it was stored. The service providers that they are typically going to are having to shut down due to the safety of their own staff and the needs to evacuate, access to being able to evacuate. And then also the day-to-day events of weather. So when a person is living outside, they are more drastically impacted by climates. So if they are it could be a rather comfortable day, but if it is rainy and all of their belongings got wet, if it is particularly hot, their hydration level may be impacted, which can be a trigger for symptoms to worsen. Something like dehydration can also impact the efficacy of medication. So all things to be considering both in big and small weather events. Loss of income and housing, certainly a traumatic event like that can really trigger somebody or exacerbate their symptoms. Changes in providers, just general interactions with others. This could be they are waiting at a bus stop and they have a negative interaction with a police officer. That could be triggering to them. Certainly singular traumatic events or ongoing trauma that they are experiencing, a new hospitalization or incarceration. This can have some very interesting impact on their symptoms because they may be receiving more controlled hydration and medication and ability to sleep and ability to resources while they're hospitalized, that then gets changed very abruptly upon discharge. And incarceration can actually be both ways as well, either improved access to healthcare and basic needs or decreased access. And so a person is coping in different ways, and then they are forced back out on, very often abruptly re-enter into society, which can change significantly and be a very triggering event for them. And then something as simple as disruptions in routines. I think we all know when things don't go, our days don't go as we had planned them to go, it can be stressful. And stress on our body is no joke for anyone. But if you are living with a serious mental illness, that stress can really heighten the symptoms you are experiencing. They can serve as a trigger for those conditions and really push somebody over the edge of moving from those symptoms being well managed to being in a more acute phase and maybe being uncomfortable for them, or being in a state where they are not realizing how severe their symptoms are. So what this means for our work, it's not just about what they are. Can we name them? There's lots of great names for symptoms. That's less of remembering those clinical names is certainly less important than identifying and recognizing them as things that a person is experiencing that is causing them strain, that is causing them discomfort. And what our role is when there are acute situations, is to really try and reduce the intensity of what that person is feeling. So this may be interpersonal. So we think of a conflict that can be interpersonal, and that we are trying to make it. I did it recently, did a de-escalation training, and we were talking about trying to make it so a person could stay in the health center to receive the services that they were there to. So they got frustrated from waiting, and that triggered them to have a verbal outburst and become more threatening. But what could we do so that they could still reach their goal while also making sure that we're keeping other people safe? De-escalation can also just be about the symptoms that they are experiencing in the moment that may not be harming anyone else, and it could be okay for them to just experience, but it's actually the goal is to prevent those serious mental illness symptoms from getting so heightened that they need to have an occurrence of being hospitalized to regulate them more. So sometimes it's de-escalating something interpersonal, and other times it's trying to see, can we bring them back to their own personal baseline so that they are more comfortable in their skin. So our goal of de-escalation is to keep people safe. That includes the person in crisis, those around you if that exists, and then also you, the person who has happened upon this person, or maybe is there because that is your role within your organization to respond to situations like this. And you really need, excuse me, assess for what level of care is necessary. And this is why noticing these symptoms as you interact with a person can be really helpful to their overall care. So if you start to notice a decrease in a person taking care of themselves, somebody who is normally outgoing, you generally interact with them in an encampment, they're normally outgoing, they always greet you, you start to notice they look a bit more disheveled, they are no longer coming out to see you when you arrive, you notice that the things that you have been bringing them, the food, the water, are going unconsumed, that are just kind of waiting or being left around. These all might be signs to you that things are decreasing. Then if you notice maybe an increase in agitation, and you might eventually get to the point where you say, this person needs a higher level of care than we are able to provide in this environment, and they are not currently willing to get that care. And so that might be a case where you involve whatever your region's response system is. In Baltimore, we have a crisis response team that can come out. We also, those of us who you can involve a police officer to emergency petition somebody if that is necessary. Everything is regulated by state, so your response system might look different, but thinking about what level of care does this person need and how can I get them to that level? You want to support a person until that appropriate professional help. So whether that be a member of your care team who knows this person well and has a strong relationship, maybe you do have to involve law enforcement or that crisis response team. So trying to support them to be safe, to stay until that appropriate level arrives. And then, as we've talked about, really identifying those changes before they become this extreme level that you need to bring in a higher level of care. So it does not require you to be a trained professional or provide immediate response to a medical crisis. You do not need to be a licensed clinician or a doctor or an NP or a psychiatric nurse practitioner in order to be able to adequately and appropriately respond to a crisis. In fact, if you have a relationship with that person, you may be the perfect person to respond and support them in a meaningful way. You don't necessarily need to know what is going on to be helpful, meaning you don't need to, if you happen upon a situation, you don't need all of the details in order to be able to support the person. You want to focus on the safety of everyone involved. And then you want to seek out trusted if you are not the person who is trusted, but you know you have a team member who knows this person well, that they feel safe with, if you can get them to be a part of the conversation, that might help de-escalate, might help a person's symptoms decrease while you're thinking about What is it that we can do to support this person both in this moment and then also help them identify what their goals are and to see if there is something that you can do as a next step.
Hey, I have
And
a question.
please.
Are there some specific words or phrases or ways to say things to help clients in ways that don't trigger them? Or if we don't necessarily know the words ourselves, um, we may think somebody's experiencing paranoia. But if we go to the person and say, "Are you paranoid right now?" That could trigger that person, especially if they are having paranoid symptoms. So, what are some specific things that we could say to a person to try to establish that rapport and engage that person?
Oh, that's such a great question. And yes, you're absolutely right. One of the best things you can do is reflect back whatever language they are using in the moment. So I think labeling things like paranoia, or uh, feeling depressed, or you don't want to tell somebody that they're manic, or you actually in that moment certainly don't want to say nobody else sees the person you're talking to. You want to start by reaffirming what they are experiencing. So and asking like, this must be scary for you, or this must be frustrating for you that people don't like, that you don't feel like people are listening, or that you are being told to do X, Y, or Z. If they are able to share with you, I was told I had to do this, like, and you should say, it must be frustrating to have somebody tell you that you should do something, and I'm telling you that's not a great idea. Um, so using their language as much as possible while acknowledging the reality of what they are experiencing. So whether that is something we are all experiencing or not, it is very real to them in that moment. And that is true, certainly of extreme psychiatric, extreme psychotic symptoms, but also of anxiety and depression and mania. Those are very real feelings for their body at that moment. And it can be helpful to try and ask them very simple, but very specific questions about how are you feeling? What is it that's frustrating you right now? How does your body feel if they start to talk about, sweating or discomfort of like this, that sounds like that's uncomfortable to you. What would help? So if they are still at a point where they are able to engage in this conversation with you, your goal in this space is to, because they are not fully in crisis at this point. And so there is an opening here to talk to the person, and also present the juxtaposition of, if there is something that they are doing that is causing them to risk getting to do what they want. So, or if it's causing them to, if they're in your building and they are shouting and they are frustrated and they start pushing things off of tables and they start getting in other people's faces, being able to create that, first find out what their goal is, and then if they are hearing you, be able to create that juxtaposition of like, I totally get that it is incredibly frustrating to be waiting for your appointment that it was 15 minutes ago. I understand you probably feel disrespected. But what I also know is that everybody here has a right to be safe. And I want you to be able to get to that appointment. But if you keep threatening other people around us, we're not going to be able to allow you to be in here because it's not going to be safe anymore. And then you won't be able to get to do what you want. So if they're able to engage in that, now you don't want to talk, and actually is great. We can move to see if it's the next slide. Um, uh, we'll come back to that one, but here's some de-escalation tips, because it is often very a fine line between talking too much and also wanting to engage that person and bring them back to a point of homeostasis, because it really doesn't, when somebody escalates, it doesn't feel good for them. They are in a level of being uncomfortable in their own skin. So we want to start by being empathetic. Do not dismiss the person's feelings. Remember, the person may not be aware of what's going on. So you want to try and gauge that from the beginning. How much are they able to engage with you? And how much of it is just creating a safe space? If they are at a point where they are no longer able to hear you or respond to you, or whoever the person that is in charge of leading this crisis response, you want to be cognitive of the fact that you're going to start to say less in that time, because they may not be aware of what you are saying. And then you might say something, they might hear one word out of the 50 you are saying, and that triggers them further. It's really important to recognize that when somebody is agitated, they need more personal space. So you might not feel like you are close to them, or this might be somebody who normally you sit next to at appointments, you are able to be in a car with, and you're used to talking in close proximity, just in a normal conversation, 2 or 3 feet away from one another. You need to give them more space. Do not assume that just because what was comfortable between you before, that is something that is comfortable for them right now in this moment. You want to use non-threatening nonverbals. This means you don't want to stand here with your arms crossed. You don't want to make direct eye contact. It's actually really helpful to position yourself at an angle, keep your hands visible, they are going to hear less than they see. So that means you need to be thinking about your facial movements, your facial expressions, any body movements. You want to keep your tone of voice level. You want to remain neutral as much as possible. You want to stand in a way that if they know you very well, that's familiar to them. If you normally stand with your hands in your pockets, that's what they're used to, you should do that. But don't square your shoulders off for them. Somebody's going to interpret that as being potentially aggressive. You need to keep your emotional brain in check. This is really hard because, especially if it's somebody you know, because this can be very difficult to watch and experience with them. And they might be throwing some barbs in your way. And so if they know you, they probably know the things that might get to you, get under your skin. You can't control the person, but you can control how you respond to them. And to Laura's question, you do really want to focus on those feelings. Facts are important, but how the person feels is the heart of what is happening in this crisis. So when a person is experiencing a crisis, either their symptoms have gotten uncomfortable for them, or they felt triggered by all of those, one of those triggers that we talked about, by something somebody said to them externally, by feeling disrespected. You want to find out what that feeling they are experiencing is. And you want to use supportive phrases to let them know that you understand, not necessarily that you agree with them. So understanding them is not the same as saying, you do not want to say, oh, you're right, you're right. Absolutely. They shouldn't have had you do that. That is not helpful to anyone. And you have now undermined all of your colleagues who maybe were appropriately enforcing organizational boundaries. But that doesn't mean that you dismiss their feelings or that you jump in right away and say, come on, you know that those are our rules. You know that you can't be doing that here. You know that we have a policy where if you're 15 minutes late for your appointment, you're not going to be seen. That's not helpful in that moment either. So you really want to focus on what they are expressing to you as the feelings and less about the facts in that moment. You'll get there. That'll be part of how you reintegrate them and how you debrief with your organization afterwards, the team that responded, but it doesn't matter as much in that moment. Do your best to ignore challenging questions. So things like, you know how that is, don't you? Or what are you going to do if I don't listen to you? Or things like that, that a person outbursts or directs right to you. You want to redirect their attention to what their feelings are and what is going on at at hand. You don't want to ignore the person, but you want to ignore whatever that challenging remarks they have are to you, because that's not going to be your path through this situation. You do still want to set limits. You want to give respectful, simple, and reasonable limits. So you also need to think about, and this will be the next one, like, what hill are you going to die on? Be thoughtful about which of your rules you are deciding to implement and be firm on, and what is potentially negotiable in that moment, and provide options whenever possible. You need to speak clearly. You want to speak as simply as possible. Don't give complex run-on sentence as your choices. And whenever possible, give the best choice first, because that's the one that they're going to hear. So if this is somebody who is really trying to be seen in your organization, but their behavior has made it so security's like, nah, man, this person's out. If it's agreed upon, you want to start by saying, either we go wait on the front porch together and you will be seen, but when your provider's ready, or you come back, you leave for the day and we try this again tomorrow. So you want to try and give the best choice first. And you don't want to give too many options here. And I would highly discourage you from saying, do this or we are calling the police. That is not there's a lot of trauma and triggering that can happen with involving law enforcement. And whenever possible, even if that is a reality of what could happen, try and have at least one other option that would not involve that, to give this person a chance to choose the thing that is not going to lead to law enforcement. You need to allow silence and don't take silence as they're not listening to you. So silence gives a person a chance to reflect. This also can create an opportunity for the brain to catch up, for the response system to cool down a little bit. That fight instinct that they had, the adrenaline that kicked that in, does start to dissipate. And if you can create these safe environmental spaces where they can be and let some of that energy out, let their body process it physically, they actually might be able to get to a point themselves where they have calmed down to a point that they can remain in the space. And you need to allow more time than you think is necessary for decision making. So once you give those options, you need to allow time. It can't be a finger on you've dialed 9-1 and your fingers on the one again before, and choose now or I'm pushing this sort of thing. You need to give this space, because when a person is upset, when they are agitated, when they are feeling a lot of symptoms themselves, they cannot decide things quickly. They feel stressed, they feel rushed, they feel pressured. That is going to trigger that emotional response again. And then, as we talked about, coming back into care, the whole point of de-escalating, rather than just calling the police and ending the situation, hopefully, is that you want this person to be in your space. So reintegration sometimes happens immediately following. As I said, if they are able to calm themselves down, you're able to go stand outside with them, get some fresh air, change the environment. You're able to wait with them in a large group room while the person or the thing that they're waiting on happens. It's happened a lot in my organization around check day. People needed their money. They had places to go. They had very concrete, real things to do. And there were 2 people giving out the checks to 60 people. And there's just only so many people that can go through that process. So it takes time. So people can get heightened and agitated around things like that. But we would always do their best to give them their money that day. It's really important that they get it. We knew there was a lot of things that needed to be accomplished. So whether the reintegration happens immediately after or some future time, next day, a week later, whatever it might be, you want to reaffirm that they are still welcome in this space. You want to try and minimize the casual conversations, especially if the incident was particularly either aggressive or loud, or it involved a lot of people. Maybe it involved some damage. You want to try to minimize the casual conversation, not just among clients, but among staff as well about the incident, and then collaborate to develop a plan for preventing it from happening again. Um, and I want to just put a note, and this is a slide you will get about the importance of when a situation, a response is particularly alarming or disrupting, you need to spend some time organizationally debriefing it. So I'm going to leave you with some strategies to support individuals with behavioral health needs. So you want to think programmatically. How can you create low barrier, no wrong doors models of care that people can access your services regardless of what symptoms they are experiencing at a moment? And you want to advocate for placements that support individuals with whatever their needs are. Sorry, this came from something else. So with whatever their needs are. So your space might not be the perfect fit, but it is the perfect fit if that's the one they are willing to walk into right now. You need to increase your frequency of engagement, integrate peers as best and as much as you can. You want to educate staff of behavioral health symptoms. So you have now done this. You don't have to be trained or licensed to be able to identify and to help support somebody who is experiencing symptoms. And then embrace a person-centered harm reduction approach. This means focusing on the conditions that they would like to focus on, that it is about reducing symptoms, not necessarily eliminating all of the behaviors. And with that, I think we are right at the top of the hour. So I am available certainly to stay for a few minutes if anybody has any questions. I'm grateful for this opportunity to engage with you. I know Laura's going to send out my presentation after the fact, and just thank you for this time together.
I have another question, Katie. When we do this work, it affects our own mental health. So do you have any suggestions or tips on things that we could do to protect our own mental health in a way that will help us help others with their mental health?
Absolutely. I think there are things organizationally we can do, things like supervision. It's a big thing in the social work world, but it supports everyone, both individual and group supervision. Having these debriefing, especially if there's been an acute episode, taking time to do it, encouraging boundaries between work and this work-life balance. Like if you have a work phone, turn it off, and I mean it. Obviously, as long as it agrees with your organizational policies. If there's an emergency phone, I recognize but I actually always carry two phones, and people were like, "Why don't you just do it through one?" And I liked and needed the ability to turn off my work phone when I was in my personal life. The people who needed me knew my personal number, and if there was some reason as a supervisor I needed to get in contact with, but it prevented some of those things that could wait until tomorrow, candidly. And then overall self-care, and that means a lot of different things for a lot of people. Everyone, that it is as simple as hydration and sleep, which everybody needs. And then everybody has their own things that they enjoy, and finding ways to bake them into, when I really encourage that, the importance of scheduling PTO, but then also finding times to bake into things that people like. So I tried to know the things that my staff liked, and infuse them in our team meetings, whether that was humor or a particular food or, whatever it might have been, to bake those into our days, because this work is hard. And hopefully we will be doing it for a long time, because the people who are meant to do it, it is really a calling. And so your communities are lucky to have you, and I want you to be able to stay doing this work. But that does mean spending some time and figuring out how you can do it and stay that level of enjoyment. And I also think finding the communities that bring you joy, like what rejuvenates your love of this work. You got into the work for a reason. So maybe it's going to a conference or a particular meeting, or starting, it's a particular annual activity. that refills your cup, or conversations with a colleague. Schedule that coffee once a month if that is a person who fills your cup and reminds you why you are doing this work. There are a lot of things, big and small. Love to do that. We actually do that training. Would love to do that in the future. It's a great conversation, and I love to hear it. And that we do a lot of interaction to hear from people, because I think whatever your ideas are, they're really great to share. What works for you, it very well may work for somebody else. But they don't have to be the big things. The little ones really matter too.
All right, any other questions or comments? You've got a lot of thank yous in the chat, some positive comments. Everybody, remember when you log out, you'll get a reminder for the survey. Please, please, please fill that out. Check our website, the coalition's website. I would say probably by Monday, it should be up there, and I will send out copies of Katie's slides to everybody. And the next community table is on October 23rd. Emotional support and service animals presented by Kentucky Fair Housing Council. You can register on our website if you haven't already. And don't forget, Bagels in the Basement is this Friday. So thank you all
That
for
sounds like great self-care.
it is.
I mean,
It is.
bagels are always, so I
We
love
feed
that.
people, we feed everybody. It's coffee and bagels, and people can just share resources and have a little bit of socialization and networking. It's not a full-fledged training. It's just getting case managers together to talk to each other.
I love it. That's great. That's a perfect example of an organizational self-care that can really help with burnout. And so that's a perfect way to end it, Laura. You're really important to do both organizationally and individually. So I love that you all are doing that. And I'm grateful for all the hard work that you all do. Your communities are lucky to have you.
Thank you. We appreciate your time today. Some really good information. And I look forward to going through the slides and kind of dissecting this again.
Thank you.
All
It's a
right.
pleasure to be with you all.
All right. Have a good day.
You too.